assessment. What's the first step? We have scene. S means for safety, which involves the dynamic risk assessment, which involves can be sharps, moving traffic, large crowds, for example. We have cause, which is the mechanism of injury or the nature of illness. And we need to keep an open mind when we come to the scene, because we never know if it's going to be expected as it or it'd be different when we arrived. And it helps you to think initially what you're going to do when you approach the patient. Next, we have environment, which includes the standard infection control procedures that we may need to be set in place when we get there. And we also involves what type of PPE is required to bring with us as well, because you never know, it's going to be some of heights, it can be water or the temperature, and there may be exposure to bodily fluids as well. Next is number of patients, so how many there is, is it from the fights, ODs, RTCs, and it helps us to determine how many ambulances is needed on scene. The last one is extra resources needed, which will be probably pretty obvious at this stage. Do we need police? Do we need mountain rescue? Any specialist critical care, the helicopter, and so on. Wow! Now that we have done the scene, next is general impressions. And by the way, this is what you do before you go to the patient. Now we have the general impression triangle. So first we have is appearance. So do they look alert? Are the positioning okay? Are they happy or in distress or in pain? Are they sitting up and interacting with you, or are they on the floor not interacting, unconscious? And the expectations of a patient can be age dependent as well. This is while you're just looking at the patient before you even start going to the patient. Next we have is worker breathing. So are they breathing fast, slow, normal? Is it obvious that they're breathing? Do they need the extra effort in breathing to breathe at all? Are they even breathing at all, to be honest? Or are they using accessory muscle use? Or are they short of breath? And the last one is colour. So are they pale? Are they flushed? Do they have cyanosis? So it's like bluish purple on their skin, like the lips or nails. And this triangle is known as the patient assessment triangle. Next we have is check for response. So we can shout to try and get the respond from the patient. This is the time you would introduce yourself if they're conscious and listens, and if the patient fails to respond, they are unconscious. So you may have to go into advanced life support or BLS, and you can gently shake their shoulders to get a response from them. Now we have primary survey. So C-A-B-C-D-E. Let's get into it. First one is catastrophic hemorrhage. Then we have airway. Then we have breathing, circulation, disability, and explosion and examine. This is all needed for the primary survey, which we're going to go through. Now we're looking at catastrophic hemorrhage. So we check for it and we try to stop the heavy bleeding before moving on. And we look for it through the blood, if it's on the ground or on the clothes, because it could be death in minutes. Next we have is airway. So there's look, listen, feel. Look is for any physical inspection of an airway. So is there obstructions such as blood, vomit, is there infection, choking and distress, and also we have a choking protocol that we follow as well. Then we have listen, so any noises that we can hear such as snoring, gurgling, silence, stridor. Then we have feel for any air movement, and then we have positioning, which includes head tilt, chin lift, jaw thrust. And then there's also things we use for the airway such as OPA, NPA, eye gel as well as required, and also oxygen. Is that we have breathing. So first you have your respiratory rate, so how many breaths you take in a minute, which is 12 to 20 in the normal range, and if it's below 10 or above 30, you have inadequate chest expansion. Then you need to look at the depth of their breathing, and then there's also oxygen saturation levels, so SpO2 for short, which you want to be over 96%, but be careful because COPD patients have their normal as well, which is not that. Then there's also IPAP, which means inspect, palpate, osculate, and percuse. And also for easier, it just means inspect, feel, listen, and tap. So inspection means the rate, the depth, distress, any scars, cyanosis, the symmetry, and accessory muscles. Then palpation is the depth, the expansion, symmetry, pain, and tenderness. And oscillations mean equality of air entry, crackles, wheeze, and stridor. Then percussion is the dullness or hyperresonance. And then we also have peak flow, which is for asthma. Then you got your ETCO2, and then any oxygen and drug administration as required. You have your positioning, and you may have to resuscitate at this stage if required, if they're not breathing. And we won't have to do this yet, but I think it's next module, which is we have the decompress tension phenothorax. Phenothorax. That's such a hard word to say. Next we have is circulation, so their pulse rate, which is you usually do on your radial. If not, it's your carotid, which is 60 to 100 beats per minute, and do the whole minute, no skipsies. And then we also make sure for the rhythm, the rate, and the volume. And then we also have the skin colour, their temp of that, and the moisture. And then we also have capillary refill time, which is centrally would be the sternum, while peripherally would be your fingertips. And then you've got your blood pressure, which you may put your cuff on, and there's systolic and diastolic, which systolic is 90 to 140 millimeters of mercury, while diastolic is 60 to 90 millimeters of mercury. Then we have the ECG, which you have your 3 and 12 lead one. Then is there any blood on the floor, which has your chest, abdomen, pelvis, and long bone. Is there any treatment as required, which would be medications such as oxygen, aspirin, GTN, adrenaline, or fluid? And that we have IV access, and is there any external or internal hemorrhage, which we have to control. Next, we have disability, which there is ACPU, which means alert, new onset confusion, response to voice, response to pain stimuli, and unresponsive. Then we check their pupils of reaction of their size, the quality, and respond to light. And then we also have look at their temperature, which the range is 36 to 37.6 degrees Celsius. And we also check their blood glucose levels as required as well. And then we also have be fast, which is anything for the stroke, which means F for facial droop, R for any arm weakness in their arms, S for slurred and difficult speech, and T for time of onset. And then treatment as required, which medication they can take is glucose, glucagon, hydrocortisone, and naloxone, but that's not limited to just those. And then if it is a stroke, then we have to have a timely transfer and then make sure there's a triage destination if it is stroke. One but not least, exposure and examine, which can be examined for the head, abdomen, back, the arms and hands, legs and feet. And we also make sure the patient maintains their dignity and warmth and keep their temperature control as well. And that we also have a quick look for rashes or bleeding. And E can stand for multiple things. They can be environment, evaluate, and evacuate. Then we treat any life-critical conditions. Then, now we know everything from the primary survey, we move on to the vital signs, history taken, and the secondary survey. Next, we have the vital signs after we covered everything in the primary survey to make sure we've done everything. So, first we have respiratory rate, then we have your oxygen saturation level, so SpO2, then you have your pulse, then you have your blood pressure, ACPVU, GCS, your temperature, you have the peak flow, blood glucose, ECG, and then we also have the nose 2 risk. So it scores from 0 or 1 to 4, then 5 to 6, or 7 or more. Or if there's an individual parameter scoring more than 3, then that is medium risk as well. Next, we have history taken. So the presenting complaint, be a detective. And then you also have your informed consent, of course, because you need their consent. So there's receive, believe, retain, explain. So for receive, patient listens and concentrates to enough to receive information being closed to them. Then believe is, can the patient understand, accept, and believe the information being explained to them? Then we have retain. Can the patient retain the information being explained long enough to consider and analyze? Then explain. Can the patient explain the information that they received and the risks involved with the clinical condition in their own words? Then we have some phrases that we like to use. So one of them is sample, which is SAMPLE, which is signs and symptoms, allergies, medications, previous medical history, last eaten, it could be food or drink, and then events leading up to this. Then we also have Socrates, which is mostly used for pain. So it's site, onset, character, radiate, associated symptoms, timing, accelerating / relieving factors, and severity. So you like pain out of 10. And there are some questions that you may like to ask them, such as closed questions such as, are you in pain? Is it difficult to breathe? Or probing questions, for example, can you explain further what you mean? Or can you tell me a bit more about that, please? Then there's also open-ended questions. Can you tell me what has happened today? Or how can we help you? Now we're on secondary surveys, so there's the system assessment, which is respiratory, cardiac, neurological, gastrointestinal, and musculoskeletal, which is done in third year. Then we do head to toe assessment, which is in later modules. Now we get into the last bit of shared decision making and patient care records. Let's go. Move on to the shared decision making. So we consider the patient's wishes, beliefs, and values, and we also, where appropriate, go by ICE, which is ideas, concerns, and expectations. And then we use what matters to you, and then also discuss further treatment and transport decisions. Last but not least, patient care records. So they have to be accurate, is sufficiently detailed, and also have self-care advice for a person being cared for. There's also the referral and the handover, which is at-mist, which means age, time of onset, medical complaint, investigation, signs, and treatment, and also supporting the writer to recall events for professional development or for real trophies review purposes. Sorry for that. And then also clinical audit purposes, being accurate, and yeah. That is the clinical assessment done, and this is just a wee table and structure to go by as well, and easier to look at. And thank you so much.